So it's now my pleasure to introduce my good friend Ntsekhe from the University of Cape Town, and is going to speak about the nexus between infection and cardiomyopathy.
Good morning, ladies and gentlemen. I'd like to start out by thanking the organizing committee for inviting me to this special meeting. I have been asked or tasked with discussing the nexus between infection and cardiomyopathy. The first three slides I'm going to show are maps of Africa showing really the burden of three types of diseases that are relevant to this discussion. HIV, tuberculosis, and non-communicable disease, and that is the nexus that I'll be discussing. So this first really is about the adult prevalence of HIV throughout the world, and the obvious area of concentration is here in sub-Saharan Africa, where despite the fact that 12% of the population is concentrated here, we actually bear 70% of the burden of HIV. And in particular, in this very dark area here, the prevalence rate is well over 10%. This shows the incidence rate of tuberculosis, number of new cases in 2010. Again, I'd like to highlight the fact that the area with the highest incidence happens to correspond to that area of HIV. The two are clearly interrelated, but again, it has or may have implication for the types of heart disease that we encounter. And then finally, this is a similar map, but this time showing case fatality rates from non-communicable disease around the world. Okay? And again, to highlight that the same areas that had a very high burden of HIV, very high burden of TB, also have high case fatality rates from non-communicable disease. You've just heard from Tino that hypertensive heart disease, cardiomyopathy, and rheumatic heart disease are the non-communicable diseases of relevance in this part of the world, followed by pericardial disease and emerging ischemic heart disease. And I'll be trying to interlink some of these diseases. So the outline basically is I'm going to review and share the outcome of some local research designed to explore this interrelationship between HIV, TB, and for the purposes of this meeting, focus on heart muscle disease and look at the epidemiology, pathogenesis, and prognosis, and a few studies that we've been involved in exploring this area. So a few years ago, I was invited to write a review looking at the impact of HIV on cardiovascular disease in Africa. And just to summarize the important points, what we said there was that HIV increases the risk of and prevalence of heart muscle disease, pericardial disease, and pulmonary hypertension, and that it seemed to alter the pathogenesis, the clinical manifestations, and natural history of both. HIV also causes a very unique, unusual manifestation of vascular disease characterized by aneurysms and pseudoaneurysms of the large vessels, but we're not going to concentrate on that for the purpose of today. So with regard to the epidemiology of HIV cardiomyopathy in areas of high prevalence, traditionally prior to the 1990s, what you had were many echo screening studies, which suggested that the prevalence was somewhere between 20 and 60%. The limitations of these studies were that they were essentially confined to sick, hospitalized patients, and the definitions of cardiomyopathy or heart muscle disease weren't really outlined. So it wasn't clear what it was we were dealing with, but certainly it was noted that heart disease in patients with HIV was quite prevalent. More recently, there have been three prospective studies that shed more light on the current burden of HIV-associated cardiomyopathy that I'm going to be sharing with you. The first my good friend Albertino just discussed, and it was a thesis study looking at the causes, treatment, outcome of acute heart failure in about a little bit over 1,000 Africans from 9 countries, which he's already gone over. He's told you the relevant demographics, including age, gender, and ethnicity of the group. And he also showed you this slide, showing the prevalence of the etiology in descending order. What I'd like to do is highlight that HIV cardiomyopathy in this prospective cohort was found in about 2.4% of patients. Of course, the study did have its limitations with addressing this specific question because testing for HIV was not systematic, even amongst those with cardiomyopathy. So there's good reason to believe that amongst those with the idiopathic dilated cardiomyopathy and pericardium cardiomyopathy, HIV did contribute, and this number of 2.4% is probably an underestimation. The next study, which I believe you had the privilege of listening to from Makubi earlier in the meeting, is a similarly designed study to thesis, but concentrating on patients with acute heart failure in Tanzania, in a hospital in Tanzania. And here, 2% of the 400 plus patients had HIV-related heart disease. All of these patients were on antiretroviral therapy, which we believe may alter the prevalence and incidence of this disease. Again, it was limited in that it wasn't clear how many patients were actually tested for HIV in terms of systematic testing. And for the reasons I outlined before, idiopathic cases, or the number of patients with idiopathic cardiomyopathy who also had HIV may have been a little bit higher. What you also noted, so the distribution of diseases is similar to that shown before, where hypertension, cardiomyopathy, and rheumatic heart disease dominate. But there's also this group of other, and the authors tell us that in this group of other were HIV and TB. But again, the proportions aren't clear. And then finally, the third important study was the one that Tino again referred to, and it came from the Heart of Soweto study, looking at the contribution of HIV and AIDS to new presentations of heart disease in this community of Soweto, where the HIV prevalence is between 15 and 20%. And as Tino described, the advantage of this study was that all patients in this 2 million population township presented for their tertiary care and heart failure and conditions to a single hospital, allowing for comprehensive capture of important data. The research question here was framed slightly differently from the 2 previous studies. Here they asked, amongst patients who were identified as being HIV infected and who were evaluated for a cardiac problem, what is the spectrum of cardiac pathology after detailed workup? So patients presented over the time period stipulated, and we can just cut to the chase here. And what they found is that about 9.7% or 518 patients were indeed HIV infected. Mean age was around 40, 62% of them were women. And again, it's relevant that 54% were on antiretroviral therapy. Of these patients, again, what we see is that HIV-associated cardiomyopathy was the dominant lesion, with pericardial disease following closely. The spectrum of disease included what we normally see in other settings, but whether or not HIV actually contributed to, say, hypertension or valve disease or right heart failure isn't exactly clear. I guess the important point to make is that HIV cardiomyopathy was by far the dominant disease. The demographic profile of these patients, the age was 41, it was predominantly female. Proportion of ART, I've already alluded to, is about 54%. It's important to note that the CD4 counts, which is a measure of immune competence in these patients, was 158. Below 200, patients start to get a lot of opportunistic illnesses that may affect the heart. And systolic dysfunction, as measured by an ejection fraction below 40%, was present in 61%. with diastolic dysfunction also being quite common. Many of the patients were quite symptomatic at the time of presentation. So what do we learn from these three modern prospective cohorts? It looks like relative to what was suggested in the 90s, the frequency of HIV-related cardiac disease is relatively low. But amongst HIV-infected patients with heart disease, then heart muscle disease and pericardial disease remain the most common, while ischemic heart disease is the least common, even in the presence of ART. This, of course, being relevant because in the developed world, it is ART-related coronary artery disease that is most described. Okay. Next, I'll switch over to what we understand about the pathogenesis of HIV-related heart muscle disease. Okay. Now, there's long been debate about the exact role of HIV. And the question that is debated is, does HIV predispose the heart to noxious injuries in the form of drugs and high cytokines and other opportunistic infections? Or is HIV-associated heart disease directly related to the HIV virus itself? This is a very nice cartoon from Circulation this year looking at the potential mechanisms of HIV-associated heart muscle disease. There you see a cartoon of the virus. And again, just to cut to the chase, what they suggest is that there are three mechanisms. The first being direct HIV-induced myocardial damage, autoimmune and inflammatory myocarditis, where virion particles left behind that are perhaps innocent bystanders lead to molecular mimicry and autoimmunity. And then finally, the toxic and infectious myocarditis that I described previously. So we, in our own way, tried to address this question by looking at a small pilot study, endomyocardial pilot study amongst HIV patients with HIV in our own cohort. And we looked specifically at the prevalence of myocarditis, the cardiotropic virus infections in patients with HIV-associated cardiomyopathy, and compared it to idiopathic dilated cardiomyopathy and heart transplant patients. We're fortunate to have a heart transplant program at our hospital. The pilot study was quite small. It was an endomyocardial biopsy study, as I suggested. We had 15 patients who were diagnosed with HIV-associated cardiomyopathy, and for the purposes of this study, we included patients with a low ejection fraction and no reversible causes, and we compared it to cardiac transplant patients and those with idiopathic cardiomyopathy. All patients underwent myocardial biopsy, a detailed histology, and we looked quite carefully at the types of viruses using PCR and immune histochemical techniques. In terms of some of the important baseline variables between the groups, their ages weren't too dissimilar, although the heart transplant patients were slightly older. The patients with HIV-associated cardiomyopathy in our cohort were 58%. Their CD4 counts were relatively preserved. It's 253. This clearly is not applicable to the other conditions. And the ejection fractions were comparable between the HIV-associated cardiomyopathy and idiopathic. Obviously, those with heart transplants had normal ejection fraction. Okay? And essentially what we're able to show on biopsy is that myocarditis was much more prevalent at about 45% in those with HIV-associated cardiomyopathy compared to those with idiopathic cardiomyopathy, where we found histological evidence of myocarditis in only some 20%. This somewhat complicated cartoon depicts the number of different cardiotropic viruses we found in the different populations of patients that we looked at. So in the far right here is the HIV-associated cardiomyopathy, and basically what it says is that we found, in fact, 6 panels of cardiotropic viruses, as opposed to the idiopathic group, where generally speaking we found between 2 and 3 different types of cardiotropic viruses per specimen. What we concluded from this small pilot study was that myocarditis is a more prevalent cause of dilated cardiomyopathy in patients with HIV compared to patients without. And I will be happy again to address some of the issues that were brought up about the diagnosis of myocarditis and what we do at our center in the question and answer time. Again, importantly, the number of cardiotropic viruses per individual patient was much higher in those with HIV. And what we believe is that at the time of immune suppression with advanced HIV, many patients have an underlying viremia, which is detected in multiple specimens in the heart, and that perhaps this contributes to progressive heart muscle dysfunction. What did we learn about the prognosis? Okay, just to give some perspective, this is the mortality from heart failure in the thesis study that Albertina discussed earlier. And what you see here is that at approximately 6 months, the mortality was a little bit under 20%. Okay, that's just to give some perspective. This is a cartoon or a depiction of survival rates from the pre-antiretroviral era in the West, showing that HIV-associated cardiomyopathy was the worst form of heart muscle disease one could get. When you looked at the multiple etiologies of cardiomyopathy, that mortality rate, the death rates were steep, and at survival out to 10 years was actually quite rare. In our small cohort of 15 patients and who we looked specifically at this question comparing to heart transplant patients and dilated cardiomyopathy, we had a 6-month case fatality rate of 56%. Okay? And this was despite the fact that many of these patients after the diagnosis were started on antiretroviral treatment, including optimal anti-failure regimens. Mortality rate was quite high. So that's really the issue around HIV-associated cardiomyopathy or HIV-associated heart muscle disease. I'm going to switch gear again to show you what's relevant to that second graph showing the high burden of tuberculosis and look at tuberculosis as a contributor to heart disease. So we know that it's the most prevalent opportunistic infection and the main cause of death particularly amongst those with HIV. And we've also noted that clinical experience and anecdotal evidence is that the left ventricular ejection fraction was depressed in patients who had HIV-associated TB pericarditis. And just to say that the main manifestation of heart disease in those with TB is pericardial disease. All right? Can you turn the lights down a little bit more, please? So what I have here are echoes of a patient who has both HIV and TB. What you see here is the pericardium. This is obviously a 4-chamber view. There you see pericardium with fibrin strands within the pericardium. And the main things to draw your attention to are the fact that the LV size is normal, but as you can see, LV systolic function is markedly depressed. Okay? This is a different patient who underwent MRI. This one is at a much later stage in the disease. Again, it doesn't project here with the lighting, but believe me when I say that they've got a very thick pericardium. So they're in the constrictive phase of their TB pericarditis. But LV systolic function, again, is markedly depressed. This is a 2-chamber view. This is a 4-chamber view, showing, again, severe myocardial compromise in someone with tuberculosis-related pericardial disease. So, otherwise, what we call myopericardial disease. This is T1 and T2 weighted images of someone, again, presenting with TB of the pericardium, so with suspected myopericarditis. And again, it doesn't project. But here, the important thing to highlight is the actual inflammation and edema within the myocardial wall. So this issue of myopericarditis has become quite important in our setting, again, where HIV and TB are quite high. We performed a small study looking at its prevalence, predictors, and outcome. It was a prospective study looking at 85 patients with TB pericarditis, 68% of whom were HIV infected. Again, this is quite common to find about 70% of patients presenting with HIV. You'll see that of those, 61% had what we would call TB myopericarditis in the form of depressed LV systolic function and elevated markers of myocardial injury like CK and troponin. And about 40% didn't have any myocarditis. Amongst those who are HIV negative, myocarditis happened much more infrequently. This again is the baseline variables, and the thing to highlight here is that amongst those who had myocardial dysfunction, again, the markers of immunity, including CD4 counts and viral loads, HIV viral loads were markedly different. The viral load was much higher and CD4 counts were much lower. Okay. And then the other important thing was the duration of TB symptoms amongst this cohort was much longer in those that had myocardial depression. One of the things we looked at in this particular study was whether or not an imbalance between regulatory anti-inflammatory cytokines such as IL-10 and TGF-beta were perhaps different. We compared the ratio of these regulatory anti-inflammatory cytokines to those of pro-inflammatory cytokines. I mentioned earlier that one of the theories was that sort of inflammatory cytokines such as TNF-alpha were perhaps responsible for the LV depressed function amongst these patients. So we looked at this, and we also looked at the nature of the cells within the pericardium. What we found was that in those with HIV cardiomyopathy, differentiation was much more towards CD8 cells, which aren't as equipped to fight TB compared to those without HIV. And as this next cartoon shows, we were unable to find major differences between HIV and HIV negative across the cytokine panel. IL-6 looked a little bit different, but most importantly, when we stratified all of these differences by left ventricular ejection fraction to see if this accounted for the myopericarditis, we found no differences. Again, we looked at survival in our cohort, and just to say that those with HIV and TB pericarditis, excuse me, I'm losing my, had the highest mortality rate with a six-month case fatality rate of 40% compared to the group as a whole, and 17% in those that didn't have HIV and TB together. So our conclusions from this small study were that TB myopericarditis is common in patients with HIV-associated TB pericarditis, that the main predictors are advanced immunosuppression as measured by CD4 counts and a high viral load, and that the duration of TB within the pericardium seemed to affect the phenotype of the pericarditis. And again, 6-month case fatality rates were quite high. So the question that is often asked is, what is the impact of antiretroviral therapy in this setting? And it seems that well, we know that antiretroviral therapy is now being made available across the continent. So in the last 5 years in particular, there's been a concerted effort to make sure that all patients who need it get access to it. Currently, South Africa has one of the biggest antiretroviral programs in the world, with over 2.5 million people now on antiretrovirals. Importantly, the World Health Organization guidelines now stipulate that antiretroviral therapy should be started in patients with CD4 counts that are well preserved, and hopefully the idea here is that you don't wait for people to get opportunistic infections, you treat them while they're still healthy, and therefore prevent any of these fatal opportunistic infections. And the idea then is that by preventing immunosuppression, HIV, viremia, these opportunistic infections, that hopefully the incidence of HIV-associated cardiomyopathy and myopericardial disease should decrease. Certainly it might account for the fact that in the 3 studies in Tanzania, Thesis, and the Heart of Soweto study, because about 30 to 60% of those populations were on antiretrovirals, that might also account for the diminution in the prevalence rates. So my time is up. I'll just summarize and conclude by saying that I hope I've convinced you that the burden of HIV and TB in parts of sub-Saharan Africa is very high, that the prevalence of HIV, cardiomyopathy, and TB myopericarditis is still unclear in terms of proper definitions, but that it's much lower than previously speculated, certainly in the pre-antiretroviral era, that amongst those who are HIV infected, HIV-associated heart muscle disease is most common, followed by pericardial disease. Viral and post-viral myocarditis seems to be the dominant mechanism of injury, and that in those with TB pericarditis, HIV does seem to predispose to heart muscle involvement with depressed LV ejection fraction. The prognosis of both HIV-associated cardiomyopathy and TB myopericarditis is quite poor, and that hopefully by introducing antiretroviral therapy early, we may be able to reduce both the prevalence and incidence of both, and in so doing, improve the overall prognosis of our patients. Thank you.
Some questions? Questions, please? Yes. Microphone.
Thank you. What were the predictors of high fatality, especially with regard to the other organ failure like cardiorenal syndrome or cardiohepatic syndrome?
You know, I understand now why Tino kept asking for repeat question. Can you repeat that again, please?
What were the predictors of high fatality? Because you mentioned 60% mortality as an... So what were the predictors? They had multi-organ failure.
Right. The biggest predictors really were markers of immune suppression. Their viral load, their low CD4 count, the presence of anemia, the presence of renal dysfunction, and things that really one couldn't reverse despite aggressive antiretroviral treatment. So they weren't too dissimilar to the predictors of mortality in other patients with AIDS. If you're speaking specifically to the HIV cardiomyopathy group, yes.
And how common was the constrictive pericarditis as in sequelae of HIV-related or TB pericarditis?
Okay, that's a good question. We've actually, I didn't show that in this study, but we've addressed this question. And what we believe is that in the setting for TB constriction under normal conditions, at between 6 and 1 year, approximately 25% of our patient cohort develop constrictive pericarditis. Amongst HIV, that proportion is reduced by between 50 and 60%. So HIV inhibits fibrosis and constriction as it does in many other organ systems. The heart is not spared that process.
We have a question over here, Pico.
As you are talking about the sub-Saharan HIV patients and
yes,
the term endomyocardial fibrosis,
yes,
it is commoner in the sub-Saharan. Is it as common as we thought before, and is it still idiopathic?
Okay, what I will do is, obviously endomyocardial fibrosis is endemic to Mozambique. So I think it probably most appropriate that you get the response from one of the world authorities that we have here.
So what's the specific question?
What is the question about endomyocardial fibrosis?
Is it still as prevalent as
before?
Thought previously? Yes.
Well,
Still idiopathic?
No. What I know is, for example, that in Nigeria, endomyocardial fibrosis almost disappeared, as well as rheumatic heart disease. It has also decreased in Uganda. But in Mozambique, we still have lots of cases of endomyocardial fibrosis. I think that endomyocardial fibrosis, like rheumatic heart disease, is related to poverty. So in the most poor countries, endomyocardial fibrosis is probably still prevalent. And in Mozambique, it is still highly prevalent.
We have time for one more question from the back.
Thank you for the good presentation. I'm Dr. Muhammad from Sudan. I ask about use of steroid in this case of tuberculosis, pericarditis, and HIV. Thank you.
Steroids in which setting?
In this case of patient presented with myopericarditis and have HIV, yes.
Okay. So one of the publications that Tino put up there was a recently NEJM paper looking at the use of steroids in a wide spectrum of patients with TB pericarditis. And what we were able to show there is that surprisingly, steroids did not affect mortality and outcomes. It reduced constriction in patients who are HIV negative. But in those who are HIV positive, it may actually lead to an increase in opportunistic infections and opportunistic malignancies. So our advice based on this comprehensive study that we conducted over 5 years and recently published is that if you've got TB pericarditis, which I think you're asking about, if you're HIV negative, use it. It reduces constriction. If you are HIV infected, unless you have markers of that suggest that you are very likely to constrict, stay away from steroids.
Thank you, Pico.
Okay, good.